My distinguished guest is Dr. Michael Singer. Dr. Singer is clinical professor of ophthalmology at the University of Texas Health Science Center in San Antonio, Texas. He's also the director of clinical research at Medical Center Ophthalmology. Dr. Singer is here today to talk about Unity Biotechnology's clinical trial of UBX 1325, a senolytic therapeutic under investigation for the treatment of diabetic macular edema and wet AMD. Dr. Singer is a principal investigator in that trial. So welcome to the OAS podcast, Dr. Singer.
Carrie, thanks for having me.
Wonderful to have you here. And thankfully you're here because I don't think any of our listeners know what a senolytic therapeutic is. So let's just start there.
So the concept of senolytic has to do with the fact that as our cells get older, you have these cells that essentially slow down their normal processes. And when you look at wet AMD and DME, you have more senolytic cells develop over time. So as your diabetes gets worse or your wet AMD gets worse, you have these these senile cells. And a senolytic agent is what we want to do is we want to stop that. We want to stop these senolytic cells, and if we can remove them from the system, then your body can restore itself and hopefully reverse some of the processes that are involved in the disease process, like wet AMD or DME.
Fantastic. So Dr. Singer, can you give us a top-line overview of the data that Unity has released thus far?
Wonderful. Happy to do it. So essentially, Unity has the BEHOLD trial, and the BEHOLD trial was a DME trial. And they looked at people who were the frequent flyers that needed a lot of medication to sustain their treatment. And they really want to find a stability point. If you look at the pivotal trials like VIVID and VISTA, patients gained vision initially, and over time their vision plateaued. So they wanted to have people who were previously treated for diabetic macular edema that needed multiple injections, and they randomized them to a UBX 125 versus sham. And they followed them over time with, good rescue criteria, so patients weren't abandoned. And it turns out if you follow them over time, patients with UBX 125, about 50% of them did not need a rescue injection in up to a year. So it really showed some positive results in terms of the fact that by using this medicine, you're able to stabilize these people in such a way that frequent injections may not be necessary. And this is obviously a big deal in our diabetic populations because they're notoriously non-compliant. So you want something that works longer. We already have something that works stronger.
Very good. So what's the current status of the trial and the anticipated timeline of bringing a treatment like this to market?
So the DME, the BEHOLD trial, with its positive results, they're going to run another trial looking at it to see if it's potential approval through the FDA. So they're going to repeat the trial. The other trial that's part of this was for wet AMD. It was essentially in the Unity trial, they looked at patients who needed frequent injections, and they gave them an injection of aflibercept followed by the UBX medication, and then they gave the aflibercept arm aflibercept every other month as per label. And it turns out when you looked at it, these patients, even though they were frequent flyers, they had lots of treatments, 4 out of the last 6 months. When you gave them 1 shot of aflibercept, it wasn't enough. Because essentially, after the first shot of aflibercept, but when they went to randomization, the aflibercept arm gained 3 letters after the second shot of aflibercept, but didn't gain any more vision. So they didn't have enough of a pre-treatment arm, and the Unity basically didn't gain any vision at all. But they didn't need a whole lot of supplementation. So although they didn't hit their primary endpoint in terms of visual acuity or OCT, 50% of people did not need rescue. So it appears to me that this trial, although was not designed the way it should have been, doesn't really disqualify the potential value of this medication going forward.
Very good. So what do you think that the impact of introducing this new class of treatment will have on clinical practice?
I think the concept is, we're really good at anti-VEGF, but the world is more than VEGF. And what we need to do is have things that are going to extend the duration of our great anti-VEGF. And I think senolytics makes sense. It makes sense that over time, there are factors that are involved that cause breakdown. Obviously, if you look in dry macular degeneration, you see all the complement inhibitors that are trying to deal with the aging population. If we can remove some of these cells, I think it'll be a great addition to our toolbox. I don't think it's going to be used alone. It's going to be used in combination, and it'll probably, over time, if we look 5 to 10 years from now, treating these diseases as we do in cancer, there'll be a cocktail of medications. Some will work on VEGF, some will work on inflammation, some will potentially work on senolytic. So again, it's very exciting to be a retina specialist, but we're just watching the dawn of a new era.
Exciting indeed. I love it. Sounds like very promising results for patients. So thank you so much for hopping over and explaining senolytic therapeutics to us here at the OAS podcast.
Thrilled to be there. Thanks for having me.
Wonderful. That's a wrap for this episode of the OAS podcast. I'm your host, Carrie Powers.